Thank you all so much for having me today. I appreciate it, and I really enjoyed this opportunity to talk, and I have some slides prepared, but I think this is also a small enough room to really engage and ask questions, so I think there's going to be plenty of time for that. I'm excited to share this idea of that we've really been working hard on and thinking about of how to transform the ICU into a learning healthcare system. One example of that I'll talk about is balanced crystalloids versus saline, but I kind of pulled that out of the title to make this broader because I think this is a broader thing that chest and critical care generally should be thinking about. How do we move forward into this next phase of clinical practice and clinical research? So I'm a critical care physician. Are you able to hear in back? All right. I'm a little bit taller than the microphone. How's that? Good. Oh, the lapel? Is that clear? Great. So I'm a critical care physician at Vanderbilt, and the thing that has always fascinated me and frustrated me is the fact that most of what we do for patients in the ICU on a given day is never been studied, or we're making choices without evidence. And I list some examples of that here. So in fluid management, the choice between balanced crystalloids and saline we'll talk about. How much fluid to give patients with early sepsis, for patients on a mechanical ventilator, what's the right mode of ventilation, what oxygen should we administer for patients undergoing tracheal intubation, what drugs should we use, what neuromuscular blocker should we use, what device should we use, what patient position should the patient be in. These are things we're doing in the ICU all day, every day, right? The bread and butter things, and yet when we make these choices, we're not making them based on high-level evidence, right? These are choices we make without clear evidence. Let me explain why I think that's a problem. I think that's a problem of arbitrary variation in clinical care. What I mean by that is we're often in the ICU faced with a patient with a common condition for which more than one therapy is available, and rarely we have good evidence to know what's the right therapy for that patient, right? And so that's a great situation to be in. We just give that patient that therapy, right? But the vast majority of the time in the ICU, we don't know which of the two therapies is best for the patient, but we still have to make a decision, right? And so we make an arbitrary decision, right? That we choose therapy A or choose therapy B. And when I say we make an arbitrary decision, I mean that we make a decision that's not based on knowing what's best for that patient, right? Maybe it's based on training. So I'm an internal medicine physician. I've always ordered saline. Surgeons always order lactated ringers, right? Or it's based on location. So AFib with RVR in the Northeast tends to be treated with beta blockers. In the Southwest tends to be treated with calcium channel blockers. Or it's based on what our hospital's EMR will let us order, or what the formulary will allow, or what the patient's insurance will pay for. The point is, it's not based on what's best for that patient, and two different treating clinicians might give the same patient different therapies. And the reason that's a problem is because that patient, when we make an arbitrary choice, experiences all the benefits and risks of that therapy, right? But we're not watching, right? We don't systematically collect outcomes. We don't improve care for the next patient and move patients up into the box where we know what's right for them, right? And this is one definition of clinical equipoise, right? When two reasonable clinicians would treat the same patient differently. I think when we identify these instances in practice where we're making an arbitrary decision, we should be trying to move to make it a random decision, right? So all of the same things in the structured variation of a clinical trial happen, right? You have a common condition, you have more than one available therapy. If you know what's right for the patient, you give them that therapy. If you don't, instead of making an arbitrary choice, allowing that choice to be random and then collecting those outcomes, the patient still experiences the same risks and benefits they would have had that arbitrary choice been made as part of clinical practice. But now we're watching, we're collecting the data, we make causal inference, and that improves care for the next patient. So I think we would want to be spending, when we don't know what the right answer is, we would want to be spending as much time in the structured variation of a clinical trial and as little time as possible in arbitrary variation. So how are we doing with this? So this is a back of the envelope estimate. For IV fluid, there are 50 million patients, ballpark, who receive IV fluid globally each year, of whom about 5,000 in a good year are enrolled in any clinical trial evaluating IV fluid. So 99.9% of patients are exposed to the risks and benefits of the IV fluids we have in practice without any attempt to improve future care, and 0.1% or less are involved in a clinical trial. Mechanical ventilation, probably 5 million patients a year who receive mechanical ventilation. Every one of those patients has a mode chosen, has FiO2 administered to target a saturation, and only in a good year, 3,000 of those patients are involved in a clinical trial. Tracheal intubation is probably the worst of all. 5 million patients or more critically ill adults undergo tracheal intubation each year, and in many years, 0 of them are enrolled in a trial that allows us to improve knowledge. In a good year, 100 or 200 patients. Right? So I think we're not meeting we're failing to spend the time and effort in this category of improving understanding and spending a lot of time where patients are being exposed to therapies that are potentially harmful as a part of clinical practice without attempting to understand those therapies. I think historically, the reason for this is that we've lived in 2 separate worlds, right? 2 total silos, one of which is clinical care, and one of which is the world of research, right? And up in the world of clinical care, you have the hospital, the busy hospital setting. You have this very broad, very diverse group of patients with different acute illnesses, comorbidities, social determinants of health. You've got all of these different physicians and APPs and other practitioners who all have their own preferences and biases about therapy, and increasingly are putting those orders in through the electronic health record, this final common denominator. And patients are experiencing the risks and benefits of those therapies, but we're not watching. We don't have any systematic way to know. And totally separate from this world of clinical care is the rarefied world of research, right? The ivory tower, in which a tiny subsection of patients who are not in any way representative of clinical practice are enrolled in trials. Those trials are executed by research personnel who deliver the interventions in ways that are not representative of how they're delivered in actual care, but it has this one beautiful feature, which is the flip of a coin, right, so that we know strong causal inference about the effects of those therapies on patient outcomes. And this world of explanatory, traditional NIH-funded clinical trials has always emphasized new drugs and new devices and ignored the existing therapies that we use every day in our practice, right? And when we get results from these trials, we know that those results are too narrow, right? An average ICU trial excludes 90% of the patients that we care for in practice, right? But they're paradoxically also too broad, because to get to 1,000 patients or 1,500 patients, these trials have had to enroll patients who have nothing in common with one another. Patients in the SAFE trial of albumin versus saline have TBI and sepsis, and the point estimate for effect goes in opposite directions, right? So these trials are both too narrow and too broad. They're expensive, they're long, and when we design a traditional explanatory trial, we design it to overestimate benefit and underestimate harm. Right? We overestimate benefit by enriching for patients likely to respond to that therapy, and we underestimate harm by excluding patients who might experience an adverse effect, such that we're not characterizing the way that that intervention would perform in practice. Perhaps most importantly, when we rarely find something that really is helpful, all of the infrastructure built to deliver that intervention exists in this separate world, and we then spend 17 years trying to translate it into practice, right? We're still talking about low tidal volume ventilation from 2001, right? So instead of this system of 2 worlds, I think we're increasingly thinking about what would it look like to have one world, to have one group of patients, clinicians, community members, hospital leaders, researchers, biostatisticians, all working together to identify common interventions for common conditions for which we don't have evidence-based practice, and working to understand the effects of those interventions for all of the patients, not some tiny subset, but all of the patients who would be exposed to those interventions as a part of routine practice. Using the electronic health record to retain that beauty of traditional randomized trials, which is when you have an arbitrary decision, make it random, so that we understand strong causal inference and produce results that are generalizable, that are representative of the actual patients we take care of, and ultimately personalized. There's a lot of talk about personalized medicine, and it applies differently in different fields. In critical care, I think in order to be able to talk about personalized results, one of the things we'll need to do is represent patient populations that are underrepresented in clinical trials. And to some degree, when you have trials or can envision trials where each of the small subgroups is bigger than the trials we've historically conducted, is when we'll be able to personalize and understand individual results. And maybe most importantly, unlike in a traditional trial where you built all of the infrastructure to deliver the intervention separate of clinical care, in this learning health system model, because you figured out how to deliver the intervention successfully to do the research, the day the trial's over, you just turn that equipment back on, turn that infrastructure back on, and you're immediately consistently applying best practices to clinical care. So that's a really hypothetical intro, and I want to ground it in two examples, one of which is the balanced crystalloids versus saline question, and one of which is our recent work on bag mask ventilation during tracheal intubation. And so the last couple of slides, the rest of the talk will be highlighting these two examples of how we might think of a learning healthcare system starting to answer these questions. Balanced crystalloids versus saline. So the most common intervention received by a critically ill adult is intravenous fluid. Probably 95% of patients in the ICU receive some intravenous fluid. And for more than a century, we've had two basic choices: 0.9% sodium chloride or saline, and so-called balanced crystalloids like lactated ringers or plasmolite. We've known for decades that these differ in their composition, and that difference has effects for patients in terms of hyperchloremic metabolic acidosis, but we've not known how the choice between these two affects patient outcomes. And so, applying this learning healthcare system framework, we developed this SMART trial, which was a cluster randomized multiple crossover trial enrolling essentially all adults who would have received these therapies in the ICUs at our hospital as a part of clinical care. When I say cluster randomized multiple crossover, I mean that a given ICU, like the medical ICU, all the patients, all the providers, all the nurses assigned to one fluid, say saline for June, then the next month assigned to another fluid, balanced, saline, balanced, so forth throughout the trial. And this design had a couple of advantages, but the big one to me for a resuscitation fluid trial was that it allowed coordination of the fluid being administered in the ICU with the fluid administered in the emergency department or the operating room. So instead of being enrolled 12, 24, 48 hours after ICU admission, patients who showed up to the emergency department would immediately be getting the assigned fluid as their very first drop of fluid. Delivery of this we thought about and were able to make pretty simple. So we just delivered this intervention in the research the exact same way we delivered in clinical care, which is our pharmacist, Deborah, stocked the medication dispensing cabinets in the study ICUs with the assigned crystalloid. And the way that we order these in practice is through the electronic health record, so we just tweaked that order so that it informed clinicians about the research and either guided them to order the assigned crystalloid or to identify one of the pre-specified contraindications to the assigned fluid. So not a huge change to routine clinical practice. Over the 22 months of the trial, we enrolled 15,802 patients, half in the saline group, half in the balanced crystalloid group. And those patients were very similar in the two groups, but more importantly to me, they were incredibly representative of the patients that we care for in our clinical practice. Patients in the balanced crystalloid group received predominantly balanced crystalloid. Patients in the saline group received predominantly saline. And based on what we know about the composition of those fluids, we had the expected findings of patients in the balanced crystalloid group having lower serum chloride concentrations, higher serum bicarbonate concentrations, which resulted in about a 10% absolute risk reduction for hyperchloremia, 7% absolute risk reduction for metabolic acidosis in the balanced group. The question was, what happened to the clinical outcomes, right? We've known this for decades. How did this affect patient outcomes? And the primary outcome for the trial was a composite of death, new renal replacement therapy, or persistent renal dysfunction. And this was lower in the balanced crystalloid group compared to the saline group, and that absolute difference was 1.1%. This is a number needed to treat of about 100. 1.1% sounds small compared to what we're used to looking for in these clinical trials, right? But these fluids are used for 30 million patients a year and have been for decades. We knew this difference wasn't going to be a 10% difference in a clinical outcome, right? So this trial was powered to detect a 1 to 2% difference between these two really common therapies. I think most of our critical care clinical trials comparing therapies are going to have to be this size or bigger to detect these differences that are meaningful, right? So if your hospital treats 10,000 critically ill adults a year like ours does, a 1% difference turns out to be a lot in terms of patient outcomes. So if this were research in the traditional model, that'd be the end of the story, right? But in this learning healthcare system model, we're very focused on the idea of this being 3 phases. First phase is observe the variation in clinical practice. Second phase is intervene to understand what's best for patients. And the third phase is implement it, right? So as soon as you know what's best, you have to be using that infrastructure to implement it. And so this is our observation phase. This is 2014 in the medical intensive care unit where I practice. We're all internists, so we all used saline, or it was 75 or 80% saline historically. During the trial, it's about 50% saline, 50% balanced crystalloids, and it just depended which month you were in. And we now know, in retrospect, that during this 22-month period, the mortality for our patients in this MICU was lower in the balanced crystalloid groups compared to the saline groups. And we all think of ourselves as astute clinicians. We were watching the whole time. We should have known after these 2 years of using balanced crystalloids and saline, the balanced crystalloids were better. If we're astute clinicians, we should have come out and ordered predominantly balanced crystalloids. But when the trial ended, before we analyzed the results, we actually ordered more saline than we had prior to the trial. And we were not able to detect those differences in patient outcomes just by our observations alone. But luckily, because we knew how to deliver the intervention in clinical care already, we had to develop those tools for the research. The day we know the results of the trial, we can flip that technique back on, right? And so we immediately went from using, historically 75, 80% saline to less than 5% saline in our ICU, and have maintained that for the 2 years since the trial. So that idea of observe, intervene, and then when you know what's best for patients, at least in your local environment, implement. The second and last example I'll give you, that study of balanced crystalloids versus saline has a bunch of limitations conceptually, right? It's only happening at one hospital system. It applies to an intervention that maybe is easier to control in some ways. So I think a second example helps frame what else this could look like. So this is our trial of bag mask ventilation during tracheal intubation, and this is a trial that happened at multiple ICUs. It's a trial that controlled an intervention that's happening at a really high acuity time point. And so I think it tests the question of whether that learning healthcare system model can apply to these other contexts. And this is, again, an age-old question. So rapid sequence induction and tracheal intubation was introduced in the 1950s, and since that time, there's been decades of debate about what to do between the time you push the induction agent and the neuromuscular blocker and the time you put the laryngoscope in the patient's mouth, right? Even though that's just a short 45 to 90-second interval, what happens when that patient stops breathing, who's often has hypoxemia and is at risk of complications? What happens, and what we should do to prevent complications during this interval has been a subject of debate. So a lot of people say, especially anesthesia people say, well, you should bag the patient. They're at really high risk of hypoxemia. You should provide bag mask ventilation here to decrease the risk of hypoxemia. A lot of critical care folks and emergency medicine folks are wary of that because bagging could theoretically increase the risk of aspiration. So what we've had is a huge amount of provider practice variation and no data. There's never been a trial of this. So we designed the PREVENT trial to address this question. This was a multi-center trial in 7 intensive care units in the United States. It included adults undergoing tracheal intubation with sedation and excluded very few patients, only those for whom the intubation was too emergent to perform study procedures, or the provider already knew the right answer for that patient. That patient was hypoxemic and required bag mask ventilation, or was actively vomiting and it would be contraindicated. Patients were randomized 1-to-1 to either bag mask ventilation or no bag mask ventilation. And patients in the bag mask group received this therapy, which most critical care people feel very comfortable delivering. Patients in the no group did not receive bag mask ventilation unless as treatment for hypoxemia or after a failed attempt. And at these 7 centers over the 18 months of the trial, we enrolled 400 patients, half in each group. And again, those patients are well balanced, but they're also very representative of the people that we intubate. This is not, the 10% fraction of patients. This is most patients being intubated in ICU are represented here. Even though this was conducted without any research personnel, right? So the people who are performing these are our fellows or attendings or nurse practitioners, right? There's not a researcher present at the bedside during emergent tracheal intubation, right? But because these procedures were successfully embedded inside clinical care, we achieved good separation of the groups like you'd expect in a traditional trial. So in the bag mask ventilation group, 99.5% of patients received bag mask ventilation starting at induction. In the no ventilation group, only 2.5% of patients received bag mask ventilation starting at induction. So wide enough separation to understand the effects of this intervention. And this is the primary outcome, so bag mask ventilation group, no ventilation group, and the oxygen saturations during tracheal intubation were higher with bag mask ventilation. And most convincing to me, I was not somebody who used bag mask ventilation routinely, the rate of severe hypoxemia during the procedure, so an oxygen saturation of less than 80% during the procedure, was 23% in the no ventilation group, which is what it's been in all of our prior trials. 24% is what it's always been. In the intervention group, the bag mask group, it's 11%. So it cut in half the rate of severe hypoxemia during tracheal intubation. And importantly, this trial wasn't powered to evaluate for the rare outcome of aspiration, but that operator-reported aspiration was numerically lower in the bag mask ventilation group compared to the no ventilation group. So reassuring there that there's not any major effect on aspiration. We kind of measured this all these other ways and didn't see any suggestion that aspirations increased with the provision of bag mask ventilation. Again, if that were a research study, that's where that would end, if it were solely an explanatory clinical trial. But we see this as part of a healthcare system, and so this is our ICU in each of those 3 phases: observation, intervention, implementation. So in the observation phase, our clinicians used bag mask ventilation about half the time. Our rate of severe hypoxemia, so a SAT of less than 80 during tracheal intubation, was 24%, which is what it's always been every time we've looked at this. In the intervention phase, clinicians used bag mask ventilation about half the time. It's just that we got to select. We turned that arbitrary variation into structured variation so that it was happening very consistently in the intervention group and essentially only as rescue in the no bag mask ventilation group. And as you can see, in the no bag mask ventilation group, the rate of severe hypoxemia was 24% in our ICU, like it's always been. In the intervention group was 7%, so dramatic decrease in the risk of hypoxemia with bag mask ventilation. And the key point from my perspective is the day we know these results, we apply it to our practice, right? So we use those same tools that we developed to implement the study, to implement the findings of it. And so it's not perfect, but we're now using bag mask ventilation in 86% of our intubations in the ICU, so a big step up from 50%. And our rate of hypoxemia, which had been 25% for as long as we've been studying it, at least 6 years, is now 13%. So probably about cut in half. So that's essentially it for me. I have 2 more slides. This is a summary. So I'd say fluid management. So a back of the envelope estimate is 3 billion patients were treated with saline before we ever studied it in a randomized controlled trial. And with the data that we have now, although it's not final, there'll be other trials like the PLUS study and the BASIC study. Balanced crystalloids appear to potentially prevent death, renal replacement therapy, or renal dysfunction compared to saline. Tracheal intubation, over 100 million critically ill adults were tracheally intubated without providing bag mask ventilation before we ever studied its safety and efficacy in an RCT. And bag mask ventilation, with the data we have now, appears to decrease the risk of severe hypoxemia without affecting the risk of aspiration. And so the point of those two, to me, is actually not about those two therapies at all. It's about the idea of, can we move forward from these old models of really expensive, really removed from clinical care, clinical trials that have tended to neglect the things that we do every day in the ICU, towards a learning healthcare system that integrates pragmatic trials into the delivery of clinical care, to generate new evidence for best practices, and maybe more importantly, to immediately apply that evidence to improve outcomes for patients. And the last slide is, I was thinking, what can the CHEST network do to help with this? How might this overlap with the mission of this group? And I don't know, but these are 5 thoughts that I had. One of which is, in order to move forward with this system, we need to encourage patients, clinicians, researchers, policymakers to challenge the idea that arbitrary variation in clinical care is somehow safe or safer than structured variation in a clinical trial. That's fundamental to all of this. So we have to work with all of these groups to challenge that assumption. Second, we have to develop new approaches to involving patients and community members in research when prospective informed consent is impracticable due to urgency or scale, that we don't have the luxury of being thoracic oncology or asthma or diseases where you can recruit patients in the clinic and have an hour-long discussion of a 5-page informed consent document. Our research environment is different, and we don't have the regulations that allow us to efficiently provide patients access to research that will improve their care. So I think this is a huge challenge that we need to figure out the right way to lead. I think we need to invest in innovative approaches to embedding each step of a clinical trial within clinical care. And I think one of the most promising areas for this is the electronic health record. With all of its problems, every step of a clinical trial, like that fluid trial, all of those steps were done without a study nurse, just by writing software applications in the electronic health record. And I think we're in an era now where we can do that. And I think it's a challenge, unmet challenge, to develop tools to estimate the effects of interventions for individual patients rather than across populations. The way we implement evidence in the future shouldn't be, we read a trial in a journal and then we have to remember to apply that, and we apply an average effect across patients, right? We should have the results of these trials be, for this 46-year-old woman you're taking care of who has traumatic brain injury and AKI, this is the right fluid for that patient. For your 99-year-old with sepsis and cholecystitis, this is the right fluid for that patient. And those models may be complex, but we can live in a world of complexity when that data is integrated into the electronic health record. So I think we need to be pushing that idea of personalizing the results of our trials and applying them in a personalized way. And then I think we have to find ways to help researchers and clinicians reflexively use the infrastructure that's available, especially, and that we've contributed to developing for trials, to implement the findings into practice consistently, so that we're not just generating evidence, we're using it to improve patient outcomes. So I thank you very much for your time, and I appreciate it, and have any questions.